evening, everyone. Uh, Myself, Dr. Manoj. I'm working as Professor, Head of the Department of Dermatology at Sri Madhusudhan Sai Institute of Medical Sciences. I welcome you all for Rare Disease webinar session, which is organized by ORDI, Organization for Rare Disease, on the topic which I would say rare among the rare diseases, that is genodermatosis. Here, the need for a skin rare genetic disease is definitely huge because there is a lot of gaps in clinical care, research domain, or advocacy domain. So this webinar will definitely mark a strong message for all the three fraternity, be it Sarkar, Samstha, or Samaj, to make sure that we need to give a lot of focused attention. Delay in diagnosis, inequality in care, research gaps are always haunted questions in our rare disease. To address these in a prototype disease of skin, which is rare, Xeroderma Pigmentosum, where there is sun damage which can't be repaired because of the genetic disease. So this disease is something which is going to be addressed today in the domain of management, which is recent trend. So we have with us Dr. Neetu Bhari, Additional Professor of Dermatology at AIIMS New Delhi. When I was reading her CV, one thing, apart from all the ICMR, IIDVL awards, fellowships she has received, is the KC Khandari Book Prize Award, which is a prestigious award given to the postgraduate during their PG life. I work with one of the recipient, Dr. Divya Sheshadri. So I know what standards they set these recipients of this award. So with no delay, I would welcome Dr. Neetu Bhari to take over this session and enlighten us with your knowledge.
Thank you so much for your kind words, Dr. Manoj, and thank you, Chetna, and the group for the invitation and for the initiation. So, as Dr. Manoj said, there is a lot of work needed in this area of genodermatosis, and today we will be focusing on a specific group known as Xeroderma pigmentosum. So, among the congenital photosensitivity disorders, that is the group, a group of genodermatosis characterized by inherent sensitivity to sunlight, Xeroderma pigmentosum is one of them, and is one of the frequent one. Xeroderma pigmentosum, these children, they are also called children of moon. They are also called children deprived from their right to light because the basic right of sunlight is not given to them in few words. In this condition, there is defective DNA nucleotide excision repair. Because of that, there is extreme sensitivity of skin and eyes to UV light that results in multiple skin and ocular tumor. In addition, there are other systemic complications in some of the types like neurological problems as well. So there are 8 complementation type within the Xeroderma pigmentosum group as well, and this is important because they differ in their clinical presentation, in the severity of the photosensitivity, thus the severity of the skin cancer and ocular cancer, and neurological symptoms. So XPA is associated with more photosensitivity and more neurological symptom, while in our country XPC is the commonest, where the photosensitivity is minimal. That's why the recognition at early age is missed, and this result in increased number of the skin cancers. This is a rare disease. In India, there are no epidemiological studies. There are few case reports and case series published from here and there. Otherwise, the incidence in America and Europe have been recorded and ranges from 1 in 2 lakh 50,000 to 10 lakh. As we discussed that this in this disease there is high frequency of skin and ocular cancer. The cancers are seen in as high as 65% of them. In addition, the age of onset for this cancer is also significantly reduced. Like for non-melanoma skin cancer, if we talk about general population, the median age for development of squamous and basal cell carcinoma is 67 years, while in XP patient it is seen as early as 9 years of age. Similarly, for melanoma, we can see as early as 22 years compared to 55 years of general population. So there is many-fold increased risk of cancer and occurring at very early age compared to general population. And this is again much more frequently in the complementation group which do not burn. That means they do not have very marked photosensitivity at early age, thus photoprotection is not used, and that results in increased number of cancers. Earlier it was thought that among the skin cancers squamous cell carcinoma is the commonest. Now we have seen and studies have reported that basal cell carcinoma is the commonest. Similarly, as we discussed, multiple type of ocular and periocular tumors are also recorded, and that result in significant morbidity in the form of loss of ocular visions and ocular complications. We started our work on Xeroderma Pigmentosum 3 years ago when we started working on this ICMR, which is Indian Council of Medical Research project. Until now, we have recorded 44 families of Xeroderma pigmentosum. As we discuss, you can see interestingly that XPC is the commonest variant in our population. Though we also saw patients from XPA, ERCC5 and other groups, but the commonest was XPC. In patient 54 point around 55% of patient they had cancers, and the median age of first cancer was, again as we discussed, was very young, 12 years. In these patients, apart from the skin manifestation, we also found that they have frequent mucosal involvement in the form of mucosal pigmentation, mucosal erosions, lip erosions, punctate erosions on the tip of the tongue, because tongue and lower lip are also photoexposed sites. There were nail finding in the form of photoneicolysis, nail dystrophy, and this was a young girl presenting with nail firm lesion in the subungual area. We thought of any cancer, either fibrokeratoma or squamous cell carcinoma. We did dermoscopy. It showed this homogeneous area or in world pattern. But when we did the biopsy, we found the keloidal collagen in the dermis, and thus it was a subungual keloid. And then we saw, examined her again, and we found that she also has keloid in the other areas as well. And we reviewed the literature. There are specific mutation which make them prone to develop keloidal tendency. In the tumors, we noted that the commonest was basal cell carcinoma, as we discussed, followed by squamous cell carcinoma, and we also saw melanoma and vascular tumors. In the among the basal cell carcinoma, nodular was the commonest, but infiltrative and other high risk tumors were also noted. This is an example of squamous cell carcinoma, malignant melanoma, angiosarcoma. So all type of skin cancer, non-melanoma skin cancer, which is squamous and basal, melanoma less frequently but more frequent than general population, vascular tumor like angiosarcoma, and various benign tumors like pyogenic granuloma, etc. were noted. When we evaluated these patients, we noted that there were two major phenotypes. That means there was a group A number of patients where both photo-exposed and photoprotected sites were involved, equally involved in the form of multiple hyper as well as depigmented macules, while there was a group 2 where there was significant sparing of photoprotected sites, but the photo-exposed sites were commonly involved. Among the group 2 also, we found there was a subgroup 2A, we named it, and which had this discrete idiopathic guttate hypomelanosis like multiple depigmented macule over the lower limb, while the others have mixed hyper as well as depigmented macules. So, when we evaluated these groups and compared them, we realized that the age as well as sun protection behavior was not determining which group you were. That means you have this inherent tendency of going to one group of phenotypic expression of Xeroderma pigmentosum. Though, if we compare the disease severity, the group 2A was having late age of onset as well as late age of onset of cancer. When we evaluated the photoaging in these patients and sun protection behavior, we realized that group 1, that means the group which had involvement of both photo exposed as well as photo protected site, had the highest sun damage. Group 2 had relatively milder sun damage. Among them, group 2A again was a less severe form. We also noted that in these patients, the aging was predominantly epidermal and dermal aging signs were not noted on the dermoscopy. Thus, though we think that in XP patient, the aging is accelerated, but it is a specific type of aging because of the specific type of UVB mutation. UVA induced damage, those are not accelerated here. So, in addition, so we realize that the probably the group 2A is a less severe form, and why this is important. That means in all these patients, we tend to start isotretinoin, we tend to monitor them very frequently because of their increased risk of cancer. But if we see phenotypic expression of group 2A, we can delay the initiation of isotretinoin because we have seen at least till 12 to 17-year age was the mean age when they were developing pre-malignant or malignant lesion. This phenotypic classification may help us in determining their photoprotective intensity as well as the initiation of isotretinoin therapy. In addition, what we saw that we understood that the disease severity was different in different complementation group as well as within same complementation group. So patient of XPC, they varied in the disease severity or the malignancy burden. So we thought that there should be a severity score so that we can identify and quantify the burden of cancers in these patients. We reviewed the literature, we did the statistical analysis, and we came out with these 8 factors to calculate the final malignant severity score, which was numbered as 0 to 9. The factor included the number of the lesion, size of the tumor, site of the tumor, surface ulceration, growth rate, bone and muscle involvement, perineural invasion, and histological subtype. This was compared to the gold standard was classification made by 3 qualified dermatologists. And this not only will help us to determine the burden of the disease but also to monitoring and prognosticate these patients. So just for the example, these are 3 different patients of XP, but we can see that this patient is in the mild group because this is having a fewer lesion and those also with basal cell carcinoma. This is moderate because these are larger lesion with aggressive form, and this is severe group because there are larger confident lesion with again aggressive form of histopathology. When we compared those 3 phenotypic group, we could identify that the group 1, which had generalized involvement, were more likely to have aggressive form of tumor, just like group 2B also, while group 2A had relatively non-aggressive form of tumors in addition to the late onset of the tumors. This was a graphical representation of the same. We can see that group 1 had 61% of high risk lesion, group 2B 79% high risk lesion, while group 2A had relatively lower number of high risk skin tumors. When we evaluated these patients histopathologically, we identify one more thing, that in sporadic population, when we see tumors, basal and squamous cell carcinoma, most of them are histologically low grade tumor like nodular basal cell carcinoma. While in this population, when we evaluated 23 tumor, many of them or majority of them were high risk or aggressive form of histopathology. And why this is important, that means in addition to the inherent tendency of developing recurrent tumor, the tumor here are of aggressive nature as well. That means if you remove them just by local excision, they are meant to recur anyways, because this we have seen and studies have shown. This is just an example of showing a nodular, which is a low risk form, adenoid and infiltrative pattern. So infiltrative is a high risk form of basal cell carcinoma. This is a basosquamous carcinoma in one of the patient, which is again a high risk form of basal cell carcinoma. So why this is important, that if you excise basosquamous carcinoma with just by local wide excision, the risk of recurrence are 12 to 45%. But if you use Mohs micrographic surgery, the risk reduces to 4.1%. That means in addition to the tendency, because of the inherent UVB repair defect, the type of tumor also determine the nature of recurrence in these patients, and probably we should use Mohs micrographic surgery more commonly, that we have now started doing compared to just wide local excision. This was again similar study showing that if it is a high risk form of tumor like infiltrative and micronodular, Mohs surgery appear to be the treatment of choice for such lesions. So, in management, since we understand that this disease is caused by UV rays because of the defect in these patients, the prime mode of management or the gold standard of the management is photoprotection. When we started recruiting this cohort, we started using sun protection behavior score as a measure of determining how intensely they are protecting themselves from the skin as well as eye from the sun. So the score was very low. That means the knowledge, one, the knowledge was not there, second, the compliance was not there, because there is no immediate photosensitivity. But on a repeated counseling, we could see the significant improvement in the sun protection behavior score and the reduction in the number of the tumor. So sun protection is very important. This is one of the example. This is one of our patient, and this cloth and the eye cover, they are available on Amazon. So we provide them the link that you use this whenever you are going out in the sun, because physical sun protection is very important in addition to sunscreen wide spectrum. This was a study done outside in 2022, and they are identify. This was a study to identify various psychosocial predictor that why sun protection is not followed as vigorously as we want them to, and they identify various factors that if it is a late age of onset, then it is a negative predictor, because he or she is not used to do a intensive sun protection. If they are not experiencing a sunburn response, as we discussed earlier, in patients who are developing immediate photosensitivity like in XPA, they are following the sun protection, but since here there is no immediate skin reaction, that's why the sun protection is not as intensely followed. Negative psychosocial factors such as holding a strong belief that since we are already on treatment, so sun protection is not needed, that also affected it negatively. But there are some positive psychosocial factors as well, such as if a patient understands that XP is a lifelong condition, so timeline, acceptance, the necessity of sun protection, automaticity, that it is in their lifestyle, that photo protection we are carrying out automatically, and avoiding going outdoor in the particular hours of day. This also in the automaticity, they give you a positive psychosocial factor for following. So this explanation to the patient and the parent family is very important. Based on this study, last year in 2024, a group also performed this study and called as Expand Trial, which was published in British Journal of Dermatology, and they have shown that a personalized and systematically designed adherence to photoprotection and how it improves the frequency of tumor, skin as well as ocular. Isotretinoin is a very important drug. A low dose isotretinoin can also be used, though in the initial study, high dose isotretinoin was used. And this was the largest cohort of XP patient with non-melanoma skin cancer. And they found significant reduction in the number of tumor after initiation of isotretinoin therapy. So we can see the graph. So this gray area is the time period when the patient was on isotretinoin. So we can see how much reduction in the number of tumor was seen in this gray area. The only problem is it is a lifelong therapy. As soon as you stop, the frequency or the intensity comes back. Frequency of developing skin tumor and ocular tumor comes back. So usually what we do is we wait till the patient is starting, we notice that patient has started developing pre-malignant or malignant, and then we put them on isotretinoin therapy, usually lifelong. Because as we understand that in different phenotype, the age of onset may be different, so we try to delay it as long as possible, and then we put them on isotretinoin therapy. There are some side effects, but they are rare and need some monitoring. In the localized lesions, there are two possible tumors, possible management. If it is small tumor, it can be excised also. But now the focus is going more and more over the non-invasive therapy. That how can you treat the lesions without going for the surgery. So topical 5% imiquimod therapy is one of important therapy. In the sporadic population, we have seen that it has been used in various pre-malignant as well as malignant skin lesions. There are reports in XP patients as well, where multiple facial basal cell carcinoma, especially if you see histopathologically, these are superficial basal cell carcinoma. Imiquimod can safely be used. If you see patient of actinic keratosis or pre-malignant skin lesion, imiquimod can be used specifically. Can be used easily. Topical 5-fluorouracil again in this on the same principle can be used. In 2024, our department, Dr. Sumesh, presented this paper where full face imiquimod therapy was used, and it was named as immunopeeling. And it was seen that it not only improved the pigmentary lesion but significantly reduced the number of actinic keratosis as well as pre-malignant as well as malignant skin lesions. So in the initial few patients, now we have started a project on it. So for initial few patients, we admitted these patients because we wanted to see the tolerability of full face imiquimod therapy, because we understand that it may cause some erythema, irritation or burning sensation, and because we also want to explain to these patients that if you develop this, you have to discontinue it for some time and then continue it. So we are giving it 5 days a week at the bedtime, and slowly we have seen very good results of them, and patient and family, they are really happy with the management. This is Dr. Savi. She is currently doing this project. In addition, in other topical therapy, which can be anti-tumorigenic or can be used in the superficial as well as localized tumors, are topical podophyllene, 25%, as well as topical zinc sulfate. Some physical therapies can also be used, like heat dermabrasion plus topical trichloroacetic acid. So these are different topical therapies which can be used not only to reduce the freckling or the pigmentation, but also primarily to reduce the number of pre-malignant as well as malignant skin lesions. In patients who have So localized lesion, either you remove it or you use topical therapies. But patient who have extensive or more aggressive or advanced lesion, you have to go for systemic chemotherapy. In these patients, so currently we are doing a project and we have identified that these patients have high tumor mutation burden. TMB is much higher than the sporadic tumors, and that's why the immune checkpoint inhibitor, they have shown good improvement in these patients with advanced malignancies. So in this study, they recruited 10 XP patients with advanced tumors which are inoperable. Then you go for these therapies, and it showed significant improvement. And these are so pembrolizumab is the commonest used immune check inhibitor. So these patients presenting with metastatic melanoma or unresectable squamous cell carcinoma, cutaneous angiosarcoma, immune checkpoint inhibitors can be used, and they show partial as well as complete regression. In the recent years, effamelinotide, which was initially used for porphyria to induce the to reduce the skin sensitivity to sunlight, have also been used in few of the project. And then there are various other experimental therapies in these patients. Vismodegib is mostly for basal cell carcinoma because it is a hedgehog pathway inhibitor, but I think now it has been replaced with immunotherapy or immune checkpoint inhibitor. And then there are potentials of gene therapy because there are some studies going on regarding gene therapies also. So these are some of the NGOs, including ORDI, which are helping our patient to raise fund for their therapies. And these patients, they need our support from the clinical point of view, from various scientists and from various organization, because it is a battle and it can be fought only when we all come together. Thank you.
Thank you, Dr. Neetu, for this detailed description and also a clean approach in terms of management. And, so are there any questions from the audience? Let's just see. Okay, if there are any questions from the audience, they can always uh, type it in the chat box. We can just have them, couple of them. Okay, Dr. Neetu, like from my end, most of the management is mainly focused on how to take care of the uh, cancer burden. Are there any innovations that has been done to make sure that there is some protection for eyes?
From ocular point of view, only management till now is protection. So they have to use UV shield. I don't think there are major research done in these area because there they present with advanced cancers. So they are doing the management of the ocular tumor, but in this particular cohort, they are not done any particular research.
So, and in your cohort, uh, have you triaged patients who are prone for ocular damage? Like, when you have a genotype-phenotype correlation, we do at the younger age, whom to actually triage as like, red zone or blue zone, so that, we can tell them
Right.
in the early stage.
So, sir, when we did their genotypic analysis, we tried to do a detailed genotypic phenotypic correlation if we can find out any particular variation which is making them more prone. So, because we understand XPC patient, they are much more prone to ocular cancers as well compared to XPA. But also the number are limited, but we could not find any particular variation. Though phenotypic presentation, as we understood, the generalized and the 2B variant, they were much more likely to develop skin and ocular cancer, but genotypically we could not identify any particular variation which is making them more prone to cancer. But XPC much more likely compared to XPA and other type.
Thank you, Dr. Neetu, for this wonderful presentation. So I think that is it from our end. Thank you
Right.
all for having joined.
When somebody has asked some questions, sir, how
Uh,
to differentiate it from pellagra?
okay, here it is. Sorry. Yeah,
Yes, sir.
Lakshmi Vasudeva. Okay. So how to do? Yeah. Yeah. Dr. Neetu, over to you.
So, Lakshmi pellagra is a nutritional dermatosis. There are two age group when we see it. We either see it in the infant or neonate or a younger age group, and either we see in the adults on either some therapy, so maybe anti-tubercular therapy, patient with alcoholism, patient with some gut disease, who are not able to absorb the niacin vitamin. So in those, again, maybe your doubt is clear, doubt is genuine, that photosensitive distribution is seen. You see lesion on face, you see lesion on neck, which is known as Castle's necklace, and you see lesion on dorsum of hand. Photo protected sites are completely spared, and the lesions are like eczematous plaque, so fissured, hyperpigmented to erythematous, well defined, very well demarcated lesions are seen. We don't see freckling, we don't see pre-malignant and malignant lesion, no ocular involvement is noted, and diarrhea is another important sign, and sometimes some neurological changes are also noted. So it is a photosensitive, photodistributed disease, but very different presentation.
So, and
Neurocutaneous, yes, sir. Yes,
no,
sir.
please tell me. Neurocutaneous?
The next question, the same Lakshmi has asked one more question, that neurocutaneous disorder, is it a differential diagnosis? So neurocutaneous disorder is all group of disorder like neurofibromatosis, tuberous sclerosis. So in XP there is a neurological involvement, particularly in XPA variant, but the manifestations are completely different than neurofibromatosis and tuberous sclerosis. Yes, sir. You were
Uh,
saying.
in your cohort, like in what is the percentage of XPC? It is more than 80.
More than 80. So out of 44 patient, I think we could identify of 38 patient and 29 were XPCs. Only 3 were A and 2 were ERCC5.
And this,
Majority were, and these are the patient not only from India, Nepal patients are also coming very frequently to us. And
mm,
there are reports that XPC is the commonest. Majority of the patients are North Indian from UP, Rajasthan, Kedar, and patients from Nepal. So XPC is the commonest.
okay. And see, and XP is not like a solo presentation. It has combination of other diseases as a syndrome. Uh,
Right.
how how have you clinically seen them? Is it if it has an association of any other DNA repair disease? Does the phenotype increase in severity, or you have seen XP being independent on its expression?
Majority are independent. Only XPA and ERCC5 we find association with cocaine or trichothione dystrophy. There the manifestation are much severe. If it is an association of syndrome, we have in our limited cohort, the manifestations were much severe than the sporadic XP patient.
Yeah,
Right.
thank you. And looking forward more of diagnostication, prognostication, which is need of the hour for XP also, where we can triage them, beat XP any. Thank
Right.
you all. I don't think any other question is there. If I'm not,
No, sir.
thank you all.